Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hello and welcome back to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and this podcast exists to help you learn all about your body, health, fertility, and your hormones. Today we are talking about two hormonal conditions that can impact your fertility, both PCOS and congenital adrenal hyperplasia, which many people have never heard of, and I actually diagnosed a patient with it this week. So I think it's something really important to understand, because if you don't know what is normal, how do you know what's abnormal, and how do you know the signs to look for? Too often in medicine, people present with a problem and the most likely diagnosis is given to them without a full evaluation or workup. There's many reasons for this. Let's just say this is part of the U.S. healthcare system, which your doctor is forced to work in if you live in the U.S. Insurance rules don't always cover things. There's not always time to go into details. And the truth of the matter is you have to be an advocate for your own health, and you can't make decisions on data you don't know. So we're going to talk about these two different conditions, how they impact your periods, your hormones, and your ability to get pregnant. Before we dive in, a few housekeeping items. Huge thanks for all your support here on the podcast. I am so thankful to all of you. After hosting this podcast for now 6 years, I love answering your questions. I feel like I've covered all the basic fertility topics in some way or another, and I really love exploring more about what you can do and really taking your questions to help fill in some of the gaps. So that means you've got to keep asking questions. One way to do this is through the As a Woman voicemail. 657-229-3672 is the voicemail number. So again, 657-229-3672. Call, leave your voicemail question. It can be totally anonymous, and I love answering those. You'll hear one later in this episode. You also can ask questions on Instagram every Monday. So these questions are asked at nataliecrawfordmd. Some of them will be answered right there, or we'll direct you to other content, but a lot of them are taken so that we can answer them in the weekly newsletter and here at the end of the podcast episodes. So go ahead at nataliecrawfordmd and answer your questions there. And then the weekly newsletter has some exclusive content, has some of my favorite recipes. It always has fertility facts or tips, some of my favorite things, and just keeps you up to date. I know right now the big thing coming up is that Pinnacle will be happening in May. So if you're a woman in medicine, you'll want to check that out. Or if you want to check out some of our digital education content, you can learn about the Pinnacle membership on the website learnatpinnacle.com. Before we kick off talking about PCOS and talking about congenital adrenal hyperplasia, it's important to think about what should be happening normally. That way, when I explain these two, we can understand where the breakdown in communication or where the medical problem is. So, menstrual cycle 101 in under 2 minutes. Every month you have a group of eggs available. I like to imagine that they are coming out of a vault. So the vault in your ovary stores all your eggs. Each month you have a group of eggs available. Each egg grows in a follicle. The brain sends out a hormone called follicle stimulating hormone, or FSH. FSH is a well-named hormone. This hormone works by telling the body to stimulate a follicle to grow. As the follicle is growing, the egg inside is maturing. That egg is making estrogen, which communicates back to the brain and tells it, hey, a follicle is growing. We don't need to have more than one. Since we're humans and we can't have litters of children at a time, that means FSH then decreases, ensuring you just have the one egg. As that egg gets closer to ovulation, high estrogen levels, it'll reach its peak. Peak estrogen levels signal to the brain that the egg is in fact mature, and the brain will send out a surge of LH, or luteinizing hormone. LH first is released in a big surge, which allows that follicle to rupture, the egg to be released, then the follicle to reform and make the corpus luteum. That corpus luteum then makes progesterone in pulses. So you'll have this pulsatile progesterone, which will support the luteal phase and prepare the body for a possible implantation. If you get pregnant, About 5 to 6 days after ovulation, the pregnancy will be arriving into the uterus. It can implant, and the pregnancy will make HCG, or the pregnancy hormone. This pregnancy hormone will then constantly stimulate progesterone production from the corpus luteum. So instead of a pulsatile release, now you have an increase in constant stimulus, have huge progesterone rise, early pregnancy symptoms, etc. If, however, you're not pregnant, the corpus luteum can only live for a couple weeks. It will die, progesterone will drop, you will get a period, and you'll have a new group of eggs available outside the vault. Any egg outside the vault that is not ovulated will die. A couple important concepts in this entire premise. Number one, when the vault is more full, more eggs come out every month. In general, this means that when you're younger, you have more eggs, and as you get older, you have fewer. But there are circumstances where you'll have more eggs outside the vault, and this can interfere with the brain and ovary communication. Number two, the brain and ovaries are not a direct pathway. Your hormones are like text messages. Your brain doesn't know what's happening in your ovary unless it gets a text. It's like my best friend Chrisley, who lives in a different state, and I don't know what's going on unless she tells me. I'm not right there. I can't see it. So it's important that you understand this hormonal communication system can easily be interrupted, or there can be interference, and this can lead to disruption in that normal process. In two of the endocrine disorders that can interfere with the ovulatory pathway and cause unbalanced hormones, as much as I don't love the word balanced hormones, you know that I like to consider your hormones are balanced if you are having regular predictable periods. So definitely PCOS and CAH are causing something very different to happen. We're going to kick it off with a question so you can understand what this might feel like, and then I'm going to go into the differences, treatments, diagnosis, questions you should ask, and what you should know.
Hi, Dr. Crawford. I'm just calling because I have a question. First of all, thank you for everything you do. I'm 34, almost 35 years old, and I believe, PCOS and non-classical congenital adrenal hyperplasia. I say I believe I have both because I was diagnosed with PCOS as a teenager, and then I later found out about CAH, but I still have a lot of the PCOS symptoms and markers like high AMH, high testosterone, and I have the adrenal levels as well, like high 17-hydroxyprogesterone. So I believe I have both conditions. And I guess I have a question about how that relates to fertility and miscarriage. A little bit of a backstory. I have a daughter, 6. She's from my first marriage. I'm now remarried. And it did take a little bit over a year to conceive her. I did take dexamethasone in the months leading up to her conception, and I used some progesterone cream, and I believe those things help. Fast forward to now, I got married to my now husband in the summer, and we have been trying since then, and we got pregnant very quickly to my surprise, but we unfortunately had a bladed ovum in October. So we got pregnant in September, we miscarried in October. It was very sad, and then we waited another cycle. We tried the next cycle, and then I ended up having a chemical pregnancy in December. And during this whole time, we were going to be seeing a fertility doctor before we started trying, based on my history, but that was put on hold with the losses. So we put everything on hold. We underwent a fertility evaluation, and we're just waiting to speak to the endocrinologist. But I just wanted to ask, in your opinion, do you think that could have caused the miscarriages? And I'm just curious your take on that. Seems like not a lot of people know about non-classical CAH. Personally, I have slightly irregular cycles, some body hair. My symptoms are pretty mild, but I've had issues with fertility in the past. So I just want to hear your opinion on this. Thank you so much, and have a great day.
All right, so I think that this brings up a good point. And before answering the question, I'm going to give you a little background on both of these two things. Many more people know about PCOS. PCOS is so often diagnosed without ruling out other causes, and I think it's really important to have context on that. PCOS, or polycystic ovarian syndrome, is the most common endocrine disease in reproductive age women. I like to describe PCOS as a stubborn ovary where the communication between the brain and the ovary is broken. So if we think about the ovarian vault analogy, imagine that in PCOS, you have a higher than average number of eggs. So if we simplify the problem down, that you're born with too many eggs or you're not running out of them at the right pace. And some of that is genetic or inherited, and some of that might be exposures or lifestyle. We don't have the full direct cause. But for whatever reason, you now have a higher number of eggs. Let's use simple math. If perhaps you are 30 and you should have around 20 eggs outside the vault, but you have PCOS and you have 40. Well, your brain has no idea that this is the case. And so your brain sends out its previously scheduled determined amount in order to get one egg out of 20 to grow. But in fact, now let's imagine, because it's sending out the right amount for 20 eggs and you have 40 eggs, each egg is getting half as much as it should. It's getting diluted amongst so many eggs, and it's not a strong enough signal to get any one egg to grow and respond in a regular, predictable fashion. To understand this side of the analogy, the same thing happens as you are running out of eggs. When you have fewer eggs, so let's say now you've got 10 eggs coming out of the vault, the brain is sending out the same amount of FSH that it would need to have 20. And one of the first signs of having a lower egg count is that now each egg is getting double the amount of FSH, and so it starts to grow faster and you ovulate faster. So the first clinical sign you might have of a lowering egg count is shorter cycles. Whereas when you have PCOS, you tend to have longer cycles or irregular cycles or even absent cycles depending on the severity. Now, as you get even to a lower egg count, closer to perimenopause, the ovary gets really refractory to FSH and the brain will start to have to work hard and send out more and more. And menopause is when the brain is sending out its max FSH and the ovaries are in ovarian failure and not responding. So in PCOS, our brain-ovary best friends are broken up. And what is happening is the brain sending out its regular amount, the ovaries are not responding. Well, why does the brain not know the ovaries aren't responding? Well, because of the high egg count. If we can imagine one single egg makes about 1 picogram of estrogen at baseline. And when that single egg is mature, it makes 200 picograms of estrogen. Well, if you have 20 eggs, your baseline estrogen is 20. If you have 40 eggs, your baseline estrogen is 40. That 40 is significant to the brain, and it thinks you have an egg starting to grow, so it doesn't get a signal to send out more FSH. The other important concept here is that the ovaries love to make hormones, and it really loves to chug them out at high levels. So it's a hormone-making factory. Hormone du jour is estrogen, and when it can't make estrogen, you can't ovulate. You can't make progesterone, since progesterone is only made after ovulation. When you're not making estrogen, because FSH to follicle stimulation is not communicating properly, the signal is not being received or working because of the amount, the ovary gets really bored and the pathway starts to switch so that it can do something. And this is where LH from the brain starts to stimulate the cells to make testosterone, and that pathway works. So now you're making testosterone. Now that testosterone is causing other symptoms. It's increasing your insulin resistance. It's causing you to put on central abdominal weight, causing you to maybe have acne or hair growth. And it is feeding back. That's a very positive mechanism. All of these other things, like insulin resistance and weight gain, are also causing inflammation, and inflammation is static interference. The brain now has an even harder time knowing what the estrogen is from the ovary. It's even harder to respond. So for PCOS, you really get caught in this really bad cycle. Well, when you have PCOS, the diagnostic criteria is called the Rotterdam criteria. Rotterdam criteria require 2 out of 3. Listen to this. This is not very specific. Irregular or absent periods, acne, hair growth, either physical or chemical, meaning lab work signs of high androgens. And then the last one is ultrasound or proof of having a high follicle count. Importantly, PCOS is not the only thing that can cause some of these high androgen signs. You can have acne, especially if you're a teen. You're going through puberty. You can have a high egg count, especially if you're younger, your upper teen years, your lower 20 years. There's other androgen producing things. Congenital adrenal hyperplasia is one of them. So what will happen is somebody might come in and be young and have acne, or they might have irregular cycles, have acne, and they get this, poof, you have PCOS diagnosis without any further evaluation done. And it's not wrong, but it's wrong, meaning they meet the diagnostic criteria. I think that's kind of crappy diagnostic criteria, but they meet it. The fault, in my opinion, is that we don't know there's not something else causing this. Again, you have to know to look, you have to bring up the red flag warning signs, or there has to be something else underlying, or you have somebody who really is trying to get to the bottom. Your insurance is a problem. It's just how American healthcare is. But let's understand, you may not be wrong, quote unquote, to get the diagnosis, meaning you met what the medical community has decided is the diagnostic criteria, but it might not actually be what is going on. And this is just a hard thing to kind of understand. We also can see that big lifestyle changes, so getting older and naturally having a lower egg count or losing weight, because fat cells also make estrogen. Let's say you have PCOS and you've put on now 40 pounds. Well, each of those little fat cells is making estrogen too. So now the brain thinks your estrogen is 80 instead of 40. It's really not doing anything. But you go lose 40 pounds and you have this drop in estrogen production because it's not being made from fat cells. And now the brain feels that difference and has woken it up a little bit. And you might start ovulating again. And this is what we're seeing with people who've been on GLP-1s or who's had extreme weight loss. Now, the other thing with PCOS is that we can often try to induce ovulation by giving you medications which block or reduce estrogen. So these are Clomid or Letrozole, which you may have heard of. So Clomid works by blocking the brain and telling the brain, hey, there's nothing here. So the brain says, oh my gosh, there's no estrogen. It went from what it thought was 40 to 0, and it's going to send out more FSH. Or it says, hey, there's less estrogen because letrozole eats up estrogen in your periphery. So suddenly now your estrogen is lower, even though it's still being made, the brain isn't sensing it and sends out more FSH. And those are both oral medications that we can use for ovulation induction. Of course, any and all lifestyle factors that can decrease inflammation can be extremely beneficial, such as weight loss or improving insulin sensitivity, changing up what you eat, improving your gut health. But there are things where people might get this PCOS diagnosis, get placed on birth control pills, or not really explained what's going on, and then they're dealing with the disease and what it might mean or learning how to treat it at a much later age when they're trying to get pregnant. As opposed to PCOS, many fewer people are actually familiar with CAH. So CAH is congenital adrenal hyperplasia. Now, CAH is a genetic disease linked to a single gene that we know about and we can screen. It's an autosomal recessive disease, which means there is a carrier and a full version, and these are considered non-classic and classic. The classic version is severe. It's diagnosed as a newborn, it's considered salt wasting, and it is diagnosed, it's on the newborn screen. So this is something that gets diagnosed much earlier. It is something that if you are a carrier of CAH, so if you have non-classic congenital adrenal hyperplasia, you want to make sure you screen your partner, because if they also are a carrier, men do not have symptoms, but you are at risk now to have a baby that could have classic CAH, which can be, as we said, very severe and can cause many, many issues, and you want to know about it so you can treat that even in utero. Well, what is it? It is an enzyme deficiency. So essentially in the adrenal glands, those are the glands that sit above the kidneys. And the adrenal glands are most famous for being important in the stress pathway and the production of cortisol. However, the adrenal glands are also really important in the production of steroid hormones and in your salt regulation system. So what happens is in adrenal diseases with CAH, this mutation in an enzyme important in the hormone production pathway is not functioning, and it leads to a backup of a progesterone precursor that can't go forward. And as our caller mentioned, this is called 17-hydroxyprogesterone. Now, 17-OHP is something that will back up, and then the pathway gets shifted and you start making more androgens. So this results in androgen symptoms also, like really bad hirsutism or hair growth. You can have even hair loss, like temporal balding or male pattern baldness, acne, weight gain, just to name a few. But CAH, because of this hormonal disruption, also can cause irregular periods, and it can also lead to miscarriage. Now, PCOS can contribute to miscarriage, not directly, but likely through the mechanism of either altered endometrial receptivity because of the high androgens or because of the insulin resistance and the inflammation associated with it. But the treatment for congenital adrenal hyperplasia is different. So you need steroids. Because of how the adrenal glands also are making steroids, by giving steroids, it can change their function and decrease the problem. It's a bigger mechanism by that, but let's just say you don't hear me talking about steroids in the treatment of PCOS. You heard me talking about lifestyle changes and ovulation induction agents. And when it comes to congenital adrenal hyperplasia, you actually need to take steroids like dexamethasone or prednisone in order to decrease the risk there. Now, CAH is often misdiagnosed as PCOS, especially in young women or without a full evaluation. Now, who do you choose to test for CAH, or who do you choose to test for PCOS? For me, if you're having amenorrhea, you're not having any period at all, 17-hydroxyprogesterone should definitely be something that we're testing for. Or if your periods are longer than every 3 months, very, very irregular, or if you're young, or if you've always had these problems, or the hirsutism, the androgens are very profound. So in my opinion, if you come in and your periods are so irregular, they're every 6 months or more, we should not just say, oh, it's PCOS, your periods are irregular and you have hair growth. You meet the diagnosis, but that is not a full evaluation for that patient, in my opinion. We should be ruling out thyroid disease, prolactin. We should be ruling out that it's not hypo, so checking FSH and LH and estrogen, checking a testosterone, a 17-hydroxyprogesterone, and a DHEAS, which is another adrenal gland hormone. So it's not hard work, that is blood work. And you might even get CAH picked up on that carrier screen, and that's another reason why we love getting a carrier screen for genetic diseases before you get pregnant. Anybody who I have ever found CAH on has been previously diagnosed with PCOS. So you can see that it is a common occurrence to quote unquote be diagnosed with both. In my opinion, it's probably CAH causing the problem. Maybe it's both of them, but probably the CAH and the hormonal changes are then also contributing towards a PCOS-like picture. Treating CAH, steroids. Now, steroids for a long time can actually have some yucky side effects. You can get a red face, weight gain, this flushing, these striae, this buffalo hump. They're not fun. They also interfere with your sugar metabolism. And so I don't love just being like, here's a pack of steroids and go take these and have sex. My opinion, I really like to pair that with ovulation induction. Since you're also probably not ovulating, do both. Give medications to help override these hormones, treat with steroids, add in supplemental progesterone. Supplemental progesterone alone is not a treatment for either of these. However, anytime you're not ovulating, there's some concern that when we give you medication to make you ovulate, that there can be some deficiency in the corpus luteum production. So extra progesterone supplementation is easy as long as it's started right, which is no sooner than 3 days after ovulation. When we look down the refractory PCOS pathway, meaning if you don't respond to Clomid, you don't respond to letrozole, what are these extra add-ons we have? The two biggest things people are adding on, one is metformin, which is improving your insulin sensitivity, and the other is actually steroids, which I don't think is helping PCOS, but I think it is capturing the people who probably have undiagnosed CAH. So I think that it's important if you do have some of these high androgen symptoms, maybe acne or hair growth or hair loss, and you have irregular cycles. If you were told you had PCOS as a child or as a young person, especially without any blood work or any ultrasound or any evaluation, that you consider talking to your doctor or fertility doctor to see if that's the case. In this circumstance, I always say if you needed fertility treatments to get pregnant in the past, that's typically where I recommend we start with your next. So steroids and progesterone after ovulation, to me, is a good natural spot. It's hard to know if these pregnancy losses were due to just bad luck. We know that as we get older, we have more aneuploidy, which can contribute to things like a blighted ovum. A blighted ovum is typically due to genetic abnormality, and that is not due to CAH or PCOS. However, we don't want to be taking that extra risk if we don't have to. So considering the steroids, consider ovulation induction pending how your periods are, or the supplemental progesterone. That is a great starting place, but also make sure that we're really evaluating those fallopian tubes now, and we're getting the semen analysis so that we can have the full picture. Talking about the adrenal gland, I want to end with our last user question, which is something that I hear all the time. And that is, what is adrenal fatigue? Should I take adrenal supplements? So we just talked about the adrenal glands and how they are important in the stress pathway. Adrenal fatigue is often described as a group of symptoms, including fatigue, being tired, body aches, insomnia, anxiety, GI upset. But importantly, it's not a real medical diagnosis. Now, that doesn't mean your symptoms are not real, so separate those two ideas. But you should not be accepting a diagnosis that's not accurate because it is not allowing you to get to the real diagnosis. For most people, adrenal fatigue means that you are fatigued and you have inflammation, something in your hormone connection pathway is not working, and this might be the first presentation of an autoimmune disease or hypothalamic dysfunction. When you take adrenal hormone supplements, so if somebody says, oh, you're so stressed, your adrenal gland's not functioning, your cortisol is low, let's take these adrenal gland supplements or hormones. This can be harmful and is absolutely not recommended. Adrenal supplements, adrenal support, stress support adrenal gland, this is usually cow or pig adrenal gland, like the tissue, ground up, and it includes a variety of other hormones, including progesterone, cortisol, aldosterone, thyroid hormones, and the FDA does not regulate supplements. We've talked about that. Every pill can be different. And so when you're taking adrenal supplements, you are taking animal-created other hormones, not just adrenal gland. And these hormones in the supplement can tell your brain to stop sending out ACTH, which is the hormone that tells your body to make cortisol. In addition to causing issues with your thyroid gland or negatively impacting your fertility if they mimic progesterone or have progesterone in them, having ACTH or your brain not sending it out can cause adrenal insufficiency, which will make all of your symptoms actually worse. And you still haven't gotten to the real diagnosis that was causing this fatigue to begin with. So please, the short answer is even if you did have adrenal insufficiency and your adrenal glands were not working, the supplement adrenal support is not what you should be taking. So please, word to caution. I hope this episode helped you learn a little bit about your body, health, fertility, a little bit about these periods, and maybe you haven't heard about non-classic CAH in the past. You've got to know what questions to ask and how do you know if you're getting the right workup for what is going on. As always, I'm so thankful for you, so thank you so much for your support. Please share the podcast and continue asking your questions at 657-229-3672. Again, that is 657-229-3672. You can also follow along on Instagram at nataliecrawfordmd, sign up for the newsletter at nataliecrawfordmd.com, and please go and check out the YouTube channel, Natalie Crawford MD, where you'll find all types of short form video, about 8 to 12 minutes, answering some of your top fertility questions. Thank you, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.